Thank you, Dr. Rajesh, for having me here. So I'll be steering away from collagen cross-linking for the moment. We'll be going into not only a tectonic but also refractive process for keratoconus, to deal with keratoconus. So as you know, in a very simplified way, myopic correction by LASIK is by taking off central tissue from the cornea, whereas in ICRS we add tissue to the corneal periphery. Now, there's some principles on which intracorneal ring segments are based. Basically, the arc of the segment, then the thickness of the segment, and the distance from the center where it's placed. So all these modify the refractive correction provided by the intracorneal ring segment by way of flattening the cornea. So that is how various companies manufacture their segments, and that is how, those are the criteria we use to insert the segments into the cornea. Now, when do you think about inserting corneal segments? Are when there is loss of vision due to keratoconus. So it can also be done in a patient with good vision, but with a very high refractive error, a very irregular cornea. So most such people do not have a corrected distance visual acuity of 6/6, so that is why the loss of lines comes into significance. Where the corneal dioptric value is more than 46 diopters, the central cornea is clear, so we're not talking about high drops or a pacified cornea. And then you need to have a minimal pachymetry of 450 microns at the region where you plan to insert the ring. So again, here we're not talking about the central pachymetry, but the mid-peripheral. Now, the conditions which are amenable to treatment by the intracorneal ring segments are not only keratoconus, but also in LASIK ectasia, after penetrating keratoplasty when the astigmatism is too great, post-traumatic patients, post-RK patients, and in post-traumatic patients without any central corneal scarring, and also in PMD, where you need to place asymmetric ring segments. When do you not place those ring segments? When you're dealing, as I said, with corneal opacities or dystrophies, endothelial or stromal. When you have recurrent corneal epithelial erosions in patients with dystrophies, or in patients with a lot of eye rubbing, in autoimmune disorders where you're not sure about the type of healing or the extent of scarring that may happen, unstable conditions like pregnancy, and in some drug intake where the cornea is also affected. You have to be cautious, like I mentioned, in patients with vernal keratoconjunctivitis, low endothelial cell counts, and large pupils, just to make sure that your segments don't come in the pupillary interface. Now, what are the types of ICRs we usually deal with? Of course, there's intacs, there's Ferrara rings, there's something called a myo ring, and all these follow the basic principles, but they have slight differences between them depending on the type of cross-section, the arc segments that are produced, and the distances from which they are kept. So coming on to intacs, which is what I am most familiar with. So it has an arc of approximately 150 degrees. It's hexagonal in cross-section. It has an internal diameter of 6.77, which in a steep ring turns to 6, and an external diameter of 8.1, which for a steep cornea can be reduced to 7.3 as it brings about greater correction. Thickness varies between 0.21 to 0.5 millimeters. The Ferrara are yellow PMMA rings with multiple shapes of arc. They have a triangular cross-section and the height varies. So you have a 600 micron base, 800 microns also available, and the thickness depends on the height of the segment. So as you can see over there, as the pyramid height increases, you say that the thickness of the segment has increased. The Kera ring is very similar to the Ferrara, only thing you have a wider number of arcs and smaller optic zones. A myo ring is a complete ring, and it is a continuous ring which varies in diameter from 5 to 8 millimeters, and it has a 0.2 to 0.3 millimeter thickness. It has an upper convex and a lower flat surface. Now, this is a manual incision of a corneal ring segment after centering the mark on the cornea and marking the area where the incision has to be made. the main incision is opened up, along with passing of the keratome used for the, it's a spiral keratome which is used to construct the channel for the ring. So as you can see, this is the manual method of doing the same procedure. The same procedure with the femtosecond is very much faster, much more accurate, and much more enhanced. So this sometimes leads to channels that may be slightly superficial or too deep, and that is why there used to be more complications when only manual techniques were used, such as extrusion of the ring either into the anterior segment or up onto the epithelium. So once channels are made, the rings are passed. And now here, this is a myo ring, and this is passed into a lamella section, like you saw the passage of the lenticule, and that goes into the interface, and it sits centering on the pupil. So it produces a uniform addition of tissue to the entire periphery of the cornea. There you can see that's it's centered, and now here to the intracorneal ring segment. Again, this is done using the femtosecond laser. The marked. Following this is the operation that is used for creation of segment pockets through which the rings are inserted. So once applanation is completed, you can see that the femtosecond laser takes place in the blink of an eye. So it is that fast, the creation of the segments, the small tunnels, and the incision as well. Now once that is made, all that is required is opening of the main incision, and then making the channels patent using the ring itself. So this dissector is usually initially used to expand the tunnels and also create the initial channel to dig into the plane and discover the plane of the segment. The rest of the dissection is done using the segment itself. So that is the ring segment. So here this has a hexagonal surface, and it's used to pass. So you can pass one segment or two segments depending on what kind of refractive error you're treating, astigmatism or large amount of myopia. And the ends of the incision are sutured using tenor nylon. So if you have large central myopic cone, you use symmetric segments. When you have a high astigmatic component, asymmetric segments, and in oval cones, you can use a single inferior segment. The mid-peripheral pachy, as I mentioned earlier, is more important. Even if the central pachy is lower, as you can see in these cases, if the mid-peripheral pachy is quite good, like in the first one, then that 450 is the cutoff for that. So you can see that there is a lot of correction of myopia in such cases. -10 diopters has been corrected in this patient. There's some amount of residual astigmatism. This brings about a lot of change in the irregular astigmatism. Yeah, this is one of our last slides. You can see how the ring sits in the posterior part of the cornea, basically because the lamellae are not as thick as the anterior one. Now, complications include, as I mentioned earlier, protrusion of the segment either anteriorly or posteriorly. There can be too superficial implantation, can have some sort of pacification in the tunnels or infection of the tunnels. There can be persistent corneal edema around the segments. And most of the studies have reported such complications mainly with the use of the manual microkeratome. And of course, intacs can be used in combination with other adjuvant technologies like ICL, CXL, and excimer laser. Thank you.
Thank you, Dr. SWAPNA, for telling us all about the intracorneal ring segment in keratoconus.